Good afternoon, everyone. Welcome to our session 1.4 on Access and Equity in Family Planning at Reprosex 2024. I warmly welcome everyone, including our Honorable Chairpersons, Professor Indralal Balasuriya and Dr. Loshan Munasinghe, all presenting authors, all participants. It's my pleasure to introduce our session co-chairs. Professor Indra Balasuriya, Chair Professor of Public Health and Dean of the Faculty of Medicine at KDU. Professor Balasuriya is not only highly respected medical doctor and public health specialist, but also a researcher with over 125 publications. His wide-ranging experience in reproductive health, family planning, and community medicine has greatly enriched the field he serves, both in Sri Lanka and internationally. Joining him is Dr. Loshan Munasinghe, a medical doctor from a Family Health Bureau at Ministry of Health. Dr. Munasinghe serves as a focal point for Sri Lanka's National Family Planning Program. He brings over 28 years of experience in reproductive health, women's health, and family planning, with many contribute to international journals. His wide knowledge and commitment to improving family health and equity continue to make a difference at both local and global level. Now I am delighted to hand over the session to our distinguished co-chairs, Professor Indra Balasuriya and Dr. Loshan Munasinghe. Thank you.
Good afternoon and thank you for the introductions. You have 10 minutes for presentation, and after 8 minutes one bell will be rung, and at the end of the 10 minutes 2 bells will be rung, so you will have to stop by 10 minutes. The last presentation is online, so after that we will have the common Q&A presentation, so please fix to time, and I will invite my friend Dr. Loshan Munasinghe for the introduction of the first presenter.
Thank you, Professor Balasuriya. Good afternoon to you all. It's my pleasure to introduce Dr. Jayaratna, currently attached to the Adolescent and Youth Health Unit, Family Health Bureau, Ministry of Health. She is a postgraduate trainee, registrar in community medicine. She obtained a MBBS degree from the Faculty of Medicine, Ruhuna, in 2012, and she has had 2.5 years of experience in public health. She has also been a medical officer of health in Deranegala in the Kakala district. She has completed her community medicine masters in 2019. She now works at the Family Health Bureau as a national level focal point for maternal and child health, and is responsible for planning, coordinating, monitoring, and evaluating the reproductive, maternal and child health and adolescent health programs in Sri Lanka. And her topic today is on male involvement in family planning in a rural setting in Sri Lanka. Over to you, Dr. Jayaratna.
Good evening, everyone. So, I'm Dr. Nadika Jayaratna. So, my topic is male involvement in family planning in a rural setting in Sri Lanka. So, family planning is a decision within the family where both the partners contribute, but traditionally it is considered mostly a women's affair. So, what is mean by male involvement? It is clients in family planning services, partners in decision making, and their supportive role for the partners' use of family planning, and change agents for a better reproductive health care and gender equity. Male involvement is influenced by their knowledge, attitude, and perceptions towards contraception. So, in Sri Lanka, though we have a high contraceptive prevalence rate, and services are considered as mostly female oriented. So, lack of communication strategies to reach men. Okay, the methodology is multi-stage cluster sampling method. There were 16 clusters. So, the pre-tested interview administered questionnaire was used. Mean age was 32.7 years. Majority was Sinhalese, and 83.3 from rural areas. All were employed, and from extended families, 99.2 of them had ever heard of family planning, and the mean number of 2.5, and there were 52.5 who knew more than 3 methods. 53.8 mentioned about maintaining adequate gap between pregnancies. Another 35.7 mentioned about limiting the number of children in the family. 35.5 mentioned about preventing unwanted pregnancies, and then their knowledge about different methods. Highest percentage male condoms, 92.4. 65.3 of them were aware about oral contraceptive pills, 32.6% aware about hormonal implants, and 17.6% about the injectables. The least awareness was about female condoms. When we asked about do they know about family planning services are being freely provided in Sri Lanka, 74.8% of them knew that 65.4% who believed that caused infertility. About legalization of abortions, 72.3% thought it is legalized. Using of condoms and prevention of STIs, so only 41.4% of them knew that it can prevent sexually transmitted infection. And about the possibility of getting pregnant while breastfeeding, 10.8% knew about, 33.1% had satisfactory knowledge on family planning, 15.4% were currently practicing any method, 79.4% were using condoms, and 19% were using natural or traditional methods. 83.8% approved using family planning methods by male spouses. The commonest reason for not approving family planning was the fear of side effects. 78.6% agreed that male participation is important in family planning. 56.9% had favorable attitudes towards family planning. 64.7% of male spouses had a good involvement in family planning decision making. 92.2% had discussed family planning methods with their spouse. 44.3% had discussed it for the first time after their marriage. Associated factors: the residence, ethnicity, age, monthly income, age at marriage, and duration married, and especially the knowledge. So the conclusion is that high percentage had unsatisfactory overall knowledge on family planning, but high percentage had a favorable attitude towards family planning. So the recommendations are increasing the participation of males, incorporate men as an integral part of the target audience, and encourage male spouses clinic attendance with their female spouses, including counseling sessions. Thank you very much.
Thank you, Dr. Nadika. Over to you, Lashan.
The next presentation is on unraveling the factors determining traditional family planning practice among ever married women in Sri Lanka. This is by Migara Karunaratna, who is a senior lecturer attached to the Department of Demography, Faculty of Arts, University of Colombo. Currently, he serves as the treasurer of the Population Association of Sri Lanka. He obtained his Master of Science degree in Business Statistics from the University of Moratuwa and Bachelor's degree from the University of Colombo. His key research areas are sexual and reproductive health, LGBTQ+, community-related health and well-being, and demographics of minority groups. Over to you, Miguel.
Very good afternoon to you all. Today I'm going to talk about the unrevealing factors determining traditional family planning practices among ever married women in Sri Lanka. I am Migara Karunaratna, so I am attached to the Department of Demography. Effective family planning is influential in improving the well-being of both the mother and child. Most of the families or couples are using birth controls or family planning to delay or spacing or limiting their childbirth. According to WHO, the family planning eliminates 1/3 of the deaths related to the pregnancy and nearly 45% of neonatal deaths. Traditional family planning methods failure rate is quite high than the modern method. Sri Lanka has been one of the nations with highly who depend on traditional family planning methods. Main objective is to identify and modeling the significant or influencing factors which affect on practices of traditional family planning methods among ever married women in Sri Lanka. Data collected by for the Demographic and Health Survey conducted in 2016. Sample size were 10,835. Binary logistic regression model for incorporate to identify what are the factors. Dependent variable was traditional family planning users and modern family planning users. Independent variables were demographic, socio-economic and programmatic factors. There were 12 questions asked at the Demographic and Health Survey which regard to the knowledge, divide into 3 categories and good, moderate and poor knowledge. When it comes to the results, according to the distribution of their ethnic characteristics, there are no such a huge difference. Highest wealth quintile are using traditional family planning methods. When it comes to the employment level of the women, higher levels of employment categories, those who are using traditional family planning method. When it comes to the age, quite higher percentage than the modern family planning users in quite higher age categories. Urban women are having high proportion to using traditional family planning methods. You can see higher modern methods usage among state sector women. Childless women have using traditional family planning methods. According to the logistic regression model, the predictive power of the model is 82.9%. Knowledge, ethnicity, decision, religion, age, education level, number of children are affect for their traditional family planning usage. Under the socio-economic category, occupation of the spouse, women, and wealth quantiles, and also programmatic factors, attending to well women clinics and taking advices from midwives are effect on traditional family planning usage. Odds of the practices of traditional family planning is high among women, those who have moderate knowledge and good knowledge. When it comes to the decision to use family planning methods taken by both together is 4.26 times higher. And also the practices of traditional family planning among women who are working as sales, clerical, machine related workers and industry are 1.2. Traditional family planning practices among women having 1 to 2 children and childless women are correspondingly 3.9 times and 1.4 times higher than those who are having 3 or more children. Women in highest wealth quintile and lowest wealth quintile are practicing traditional methods than the moderate wealth quintile. Conclusion of my presentation: level of knowledge, number of children, women's occupation and women's wealth quintiles are mainly influenced on practices of traditional family planning methods. As a recommendation, can plan awareness sessions by medical doctors and midwives by targeting those women in reproductive age span and forming promotions and counseling sessions on modern contraceptive methods in different sectors and also organizing media awareness campaigns. So thank you very much.
Thank you, Mr. Migara Karunaratne. Now, Roshan, over to you.
Thank you. May I present the next presenter, Dr. Pallavi Sonu. She is going to present on exploring service provider perspectives on LNG intrauterine system deployment in Family Planning Association of India clinics. She is a public health professional working with Family Planning Association of India since August 2022 in the capacity of Program Manager Medical. She has been in the field of public health for over 7 years. She has an experience of working in public and private sector in managing and leading program activities with focused work around maternal health. At present, she is leading clinical services delivery implementation through clinics of FPA India. Thank you. Over to you.
Good afternoon everyone. So I will be presenting on exploring service providers perspective on LNGRUS deployment in Family Planning Association of India clinics. So LNGRUS is levonorgestrel intrauterine system placed inside the uterus. So it is similar to copper IUD, but this is a hormonal IUD which contains 52 milligram of progesterone. Once it is inserted, so daily 20 microgram of IUS is released. It is a contraceptive and along with that it is also used as a treatment for menorrhagia or endometriosis. According to the NFHS 5 national data, so around 56.5 were using modern method. Only 2.1% of them were using IUD or postpartum IUD. Injectables, condom or oral pills, recently implants are also available through government sector. But LNGRUS is only available in private sector and it is very expensive. FPA India introduced LNGRUS around 4 or 5 years. This was donated to us by ICA Foundation. So my objective of this paper would be to assess the perspective of service providers in introducing LNGRUS in FPA India clinics. Family Planning Association of India was founded in 1949. Currently there are like 44 clinics or pan-India. So around 15 clinics were provided with LNGRUS. We chose 6 clinics. Those are based in West Bengal, Karnataka, Uttar Pradesh, Gujarat and Madhya Pradesh. In-depth interviews were conducted with 6 medical officers and 6 counselors. Thematic analysis was conducted. How was the follow-up process followed with the clients and what challenges they were facing. The demand generation and counseling is a major part of it. This is also inserted into the uterus. There was initial reluctance by the clients. So therefore, multiple counseling sessions were required with the clients, convincing them that this is a contraceptive and also a treatment option. After 6 months, then after a year, so clients expressed that they were satisfied. So most of the providers providers emphasize that counseling is a major part because there are bleeding changes with this LNG-IUS. It helps the client to understand that what changes their body will be undergoing. Local health workers like Ashas and Anganwadis were also, involved into this and sensitized for this LNG-IUS system. So we had developed informational material also that is also helpful to make the clients understand that what system this is and how different it is by other than the IUD. Almost all the medical officers showed a positive attitude because they understood how the mechanism of action between both of them. So without any, everyday reminder of a pill or something or undergoing a major surgery, so this option was helpful for them. For the insertion and removal process, so trained practitioner is required. They found it similar to IUD. It had fewer side effects and also there were positive testimonies from the client. Clients were highly satisfied. There were less removals and also those who had used it for HMB, so they had noticed the reduction in bleeding. This is one of the poster that we had developed. So these are some of the testimonials of the counselor and medical officers. Community meetings were helpful for implementing this LNGIS into system. So it is beneficial in improving anemia and it enhances the quality of life. Thank you everyone for listening.
Thank you, Dr. Vinakar, for that interesting qualitative research. We will go to the next presentation.
The next presentation is by Tapasi Grahacharya, who is a project manager for FPA India, and she's been there for 6 years. And she has done a master's in social work and also a postgraduate diploma in management. And her presentation is on overcoming the social cultural barriers for accessing family planning service by communities through informed choices in Noida slums in India. Over to you. Thank you.
This is a project we are implementing in Noida since 5 years. I am sharing the outcomes of the project. The title is Overcoming the Socio-Cultural Barriers for Accessing Family Planning Services by the Communities of Noida through Informed Choices. Noida, it's a planned city in Uttar Pradesh. There are 1,53,000 households with a population of 6,37,000 as per the census 2011. There are contraceptive prevalence rate is 74.6%, but as per our baseline survey, we found it's 28% among the currently married women. Among the male, it's 30%. So the objective is to increase the modern contraceptive prevalence rate by 30% from the baseline and to enable the young people to make informed choices regarding contraception and by overcoming the socio-cultural barrier. So this is the methodology. One is baseline household survey. It's conducted in 2 phases. One is mapping and house listing and individual interview, and under impact assessment we conducted focus group discussion and individual interview. So this is some key findings of the baseline. 68% male, 53% females know about the family planning. 15 to 19 years male and female both are not using any family planning methods. Age group of 20 to 24, only 7% female and only 3% male are using any contraceptives. Under impact assessment in the age group of 15 to 19 years, it increased to 29% and 46% females in the age group of 20 to 24 and 42% male in the age group of 20 to 24, they are using contraceptives. Strategies used: home visits, female group sessions, couple group sessions, sessions with the parents, with the in-laws, with the daughter-in-laws, mother-in-laws, and doorstep delivering information and contraceptives, liaising with the public health facilities and accompanied referral for the injectables, IUCD insertion and sterilization, comprehensive sexuality education, training of peer educators, community-based providers and frontline workers, information education communication and behavior change communication to address the barriers, mainly the barriers to the religious practices, refusal on the part of the partner, the perception, low involvement of the male, pressure to having more children. These are the socio-cultural barriers. So the contraceptive prevalence rate has been increased from 28% to 54%. Among the male, increased to 57%. That's before, when we initiate the project, people were very shy to talk about the family planning and SRHR issues. Now the awareness level, especially among the females, have been increased. Voluntarily they are coming and accessing family planning service and bringing their male partners for counseling. The knowledge have been raised among the males from 68 to 89% and among the females 53 73 to 78%. To increase the family planning services, spreading positive messages, individual counseling and group counseling, motivating the couples for using family planning services and methods, using male users as goodwill ambassador to motivate other males and couples, mother-in-law's confluences, sustainability point of view, training of the youth, peer educators, frontline workers, community-based providers as family planning educators. Community mobilization plays a crucial role for overcoming the social cultural barrier for promoting family planning methods. Thank you.
Thank you, Grabacharya, for that excellent research, very successful work. Over to you, Lushan.
Thank you. So the next presenter is Vaishnavi Gengatheeswaran, and she is a fourth year medical student at the Faculty of Medicine, University of Jaffna. As a first time researcher, Vaishnavi is focused on the knowledge and practice of contraceptive methods, and her presentation is on knowledge and contraceptive methods among reproductive age mothers attending a tertiary care hospital in the northern parts of Sri Lanka. Over to you.
Very good afternoon to everyone. I am Vaishnavi Gengatheeswaran, a fourth year medical student from Faculty of Medicine, University of Jaffna. Even though the government and NGOs are providing a lot of services, still the unplanned pregnancies and unsafe abortions are in the higher rate. We wanted to find, we are giving the service, why is not getting to the people? The objective was to assess the knowledge and current practices of contraceptive methods amongst reproductive age mothers attending a tertiary care hospital in northern Sri Lanka. Specific objectives were to determine the prevalence of contraceptive use amongst women, to determine the knowledge of side effects, contraindications, proper usage of contraceptives, to identify the socio-demographic factors, how they influence the knowledge and prevalence of contraceptive methods amongst women. The study design was a hospital-based descriptive cross-sectional study in the pediatric hospital and teaching hospital Jaffna. Mothers who are aged from 16 to 49, sample size was 389. Technique was systemic sampling method, and the study instrument we used was an interview administered questionnaire. Total response was 359, 33.7 was the mean age. Most of them were Hinduism followers in a nuclear family, education level above the GCOL, and the monthly income less than 75,000. Housewives are the most common people. And the number of children the people are having 2 or less 74%. 98.3 participants were aware of the concept of contraceptive methods. Most of them show familiarity with condom, oral contraceptive pills, intrauterine devices, and injectable devices. And most of them got the contraceptive was given from an MOH office. 198 participants were practicing some type of contraception, and we assessed the knowledge using 19 questions. The least score from 0 and the highest score is 16. The mean marks was 5.8. 21% were using sterilization, followed by implants, condoms, injectable contraceptives, oral contraceptive pills, IUCD, and the least of them are using the natural contraceptive methods. 155 people were not using any contraceptive method due to the fear of the side effect. 23% they don't know why they are not using any contraceptives. It is followed by the planning to have children soon, cultural religious belief, partner disapproval. The fear of side effect is 34%. Actually had a negative effect previously are only 3%. When we asked about the side effects, only 52% had the weight gain, irregular excessive bleeding, headache or spotted bleeding or nausea or breast tenderness. Only 35.9% have ever had a side effect. 21 people are used the contraceptive pills. Some of them didn't know about that concept. 6% have encountered a contraceptive failure. Only 79.7% know that condoms can prevent the STIs. When their education is higher than the GCO level, their knowledge is very significantly correlated. And when the monthly income is more than 75,000, there is a significant correlation. And when the occupation of the participant is other than being a housewife, they have a correlation with the p-value 0.046. When their children's number is more than 2, they are using more contraceptive with a p-value of 0.004. When their monthly income is less than 75,000, there is a correlation with the p-value of 0.014. When the partner's highest education level is less than GCO level, that also have a correlation with the p-value of 0.032. In conclusion, even though the many participants have the knowledge about contraceptive contraceptive methods, their knowledge is very poor, and there's a serious lack of knowledge regarding the emergency contraceptive pill as well as contraceptive used in the prevention of STIs. Significant proportion currently using a form of contraceptive, and the failure rate is fairly low. Socio-demographic factors affecting the knowledge and practice. So recommendations are, we have to give education on side effects of the contraceptive to the eligible couples by the healthcare professionals. And our second recommendation is, steps must be taken to debunk the social taboo surrounding contraceptive usage at the community level. And the other one is the incorporating modern technique. Thank you.
Thank you, Ms. Vaishnavi. I think your team is also here, so you have done a good study on some uncharted territory. Now I invite the last to introduce the last presenter.
So the next presentation is online. It's by Dr. Lopamudra, and she is based in Pathfinder in the India office in Delhi, and she serves as the male lead for India. She holds a PhD in population studies from the Jawaharlal Nehru University and has 18 years of experience in the development sector, focusing on family planning, SRHR, maternal and child health, and neonates, communicable diseases like TB. Her expertise lies in designing and implementing male frameworks and research on social behavioral change communication, behavioral dynamics, gender and social norms, and digital health. She has worked with donors like UNICEF, USAID, BMGF, CIFF, private sector donors. She also serves on several ethical review boards in India, overseeing research involving human subjects. And her topic and presentation is on measuring reproductive autonomy among married youth in India, a new model. Over to you.
Hello everyone. Today I'm going to present about reproductive autonomy among young women in India and how we have measured through a project called BMJ funded project in India. I am Dr. Lopamudra Paul, Director leading the MEO, Monitoring Evolution and Learning in Pathfinder India Country Office based in New Delhi. Reproductive autonomy. It's defined as to having a power to decide on and also control the matter about your pregnancy, childbirth. It actually based on the woman empowerment and ability to make their own life choice. Woman reproductive intention, which is influenced by the relationship with her sexual partner. So, but that varies with the culture, the context, the environment, the conceptual framework adapted from studies in family planning by Dr. Upadhyay and others, that how women's reproductive autonomy has been influenced, how it has been gone for the ability to control for spacing, timing, and number of pregnancy and birth. With the support of the community, then there is an achievement of reproductive intention. In this particular model, we have 14 criteria broadly divided in 3 criteria: freedom from the coercion, communication between the partner, and the decision making. So in India, we have conducted a survey post and pre within the gap 3 years to see the reproductive autonomy in 10 districts span over 5 each in Bihar and Maharashtra, to understand that how this reproductive autonomy has been helped people to increase the contraceptive use in a married couple. It was in a cross-sectional mixed method study. We collected responses from the 229 currently married women. We have seen that 70% women do not agree with any of that they have in a contraceptive. 60% said that they have the spousal communication in the contraceptive use, and the 70% women have said that the power of the decision making of the majority of them has told that they are taking the decision jointly with their husband. So when you go for the scale, we'll find it out woman alone has a very little say, whereas the respondent with the husband jointly have a more say. The same woman has been asked few more questions in the qualitative manner to find it out that why this kind of results has been come up. So we found it out that they are everything according to their mother-in-law. They have no choice and express their view. So the more cultural context, the environment, more of the society where she sleeps matters. We have actually worked with the norm shifting intervention to address the social and gender norm. So therefore, we had a model which has been come up very well taken by others. Interpersonal strategies, communicative strategies, linkage with the services and individual strategy. Thank you.